Now let's look at what cost accounting should enable us to do, most important of which is determination of total cost of care, despite that a standardized definition of total cost of care is elusive. In fact, defining total cost of care is one of the priority things that our health system needs to do in order to be successful at value-based care. Health Partners is a provider-sponsored health plan that defines total cost of care for itself as a measure of the total cost of treating a population in a given time period expressed as a risk-adjusted per member per month cost. The National Quality Forum, or NQF, is a private sector organization that serves as the nation's convening body to establish national priorities and goals to achieve health care that is safe, effective, patient-centered, timely, efficient, and equitable. It endorses standards used to measure and report on the quality and efficiency of health care in the U.S. NQF has endorsed the Health Partners measure of total cost of care, which it calls total cost of care and resource use, that allows for cost and resource use comparisons between providers, insurers, and regions. Just as with cost accounting itself, various other measures of total cost of care are used. And within each variation, there are variations in relative risk scores applied to adjust for risk. Such variation makes it difficult to make comparisons. In general, health plans have not been transparent with their formula for total cost of care, and the relationship between risk adjustment for premium setting and making coverage determinations is significantly different from provider use of risk stratification to identify patients with emerging health risks. Providers need to calculate total cost of care at the service line level and per activity, especially to identify cost variations in practices and to negotiate for bundled payment. An analytics engine and transparency by both health plan and provider can help contracting immensely. This could also push plans and providers to improve revenue cycle processes. Many are calling for a transparent costing approach that is comprehensive, accurate, and modern, and backed by technologies that enable decision making based on cost data that previously were unavailable. Well, what does this all take? What does it mean to acquire a cost accounting system and calculate unit costs? Obviously, with 88% of providers identified in one study conducted by the Healthcare Financial Management Association, there's a lot of interest, but not as much success yet as desired, as only 17% seem to be hitting their target goals. It must be noted, however, that such cost accounting activities or their improvements are very new. In order to make the shift to really taking advantage of cost accounting, experts suggest it is necessary to develop a project plan as you would for any other new project. Executive sponsorship is critical, and although it seems like executives would be the most interested, we must appreciate that this is all very new for executives who may be somewhat challenged themselves in understanding the methodologies and even the results in some cases. We also need to remember that executives will include physicians for whom cost accounting could be viewed as yet another way hospitals are trying to lower costs, including the physician's revenue source. Once over the hurdle of gaining executive support, it is recommended that an RVU manager be identified for each clinical department. This RVU manager will need cost accounting training and time allocated to perform the work. The RVU manager should have some knowledge of medical terminology and procedures, have a high level of attention to detail, and be able to monitor the need for continuously updating the charge master, as well as to manage the service code request process as any new service is added. The RVU manager does not have to be a professional nurse for the nursing department, lab tech for the lab, and so forth. In fact, it might be better for the person to be familiar with the department but not have a professional load. Cost accounting training will also be needed for others in the financial departments, other revenue cycle areas, and IT. Since it may be an overwhelming task to look at every RVU, analytics should be applied to help identify the most strategic RVUs so attention can be focused on them. These types of analytics are frequently outsourced, which relates to another consideration for acquiring a cost accounting system, and that, of course, is the cost not only of the system itself, but staff and/or outsourcing support required to set up, run, maintain, and integrate results into yet other analytics processes. Once the cost accounting system and its associated processes are implemented, there should be a period of time in which it might be considered running in pilot mode, with a review and refinement process that should be applied then and actually to subsequent ongoing work. This will also require both the RVU managers working as a team and some external expertise. Review and refinement, as I said, is not limited to the pilot. It should be an ongoing activity, yielding a system that is well maintained. Most experts also agree that a periodic, comprehensive review should be undertaken, almost as an audit, to ensure there is no fraud or abuse of the privileges of this position. We've used the term data integration when we talk about convergence. Let's look at this a little bit more closely. Cost accounting relies heavily on accurate data that factors into the entire cost accounting process and beyond to the analytics performed with cost accounting data. From an IT perspective, convergence of financial, administrative, and clinical data is often considered data integration. Data integration is taking data from multiple disparate source systems, making sure the data are clean, and then loading the data into a data warehouse where subsequent programs are used to perform analytics. Both front and back-end processes relating to data integration in a warehouse have important components to be addressed. Front-end processes should start with ensuring there are data entry standards and interchange standards for the source systems from which data will be extracted for placement into the data warehouse. These include edit rules at the point of data entry, data reconciliation checks, and other accuracy reviews. Interchange standards are required should the source data be in one system moving to another, such as patient demographics being entered initially into a registration system, with some of this data being moved to various clinical systems as they may be used during patient care. If data from the secondary source system is used instead of the primary source system, it must be exactly the same as the original data. Data specifications in terms of the nature of the data being entered into the source system should be documented in a data dictionary, which itself is a database requiring continual maintenance and which should be used consistently across all applicable IT platforms. Source data must be placed into a data warehouse in the correct format, so the source of the original data must be mapped to the target location in the warehouse. Most data warehouses use a data architecture to model precisely what data are required and what data in what format go where, all to accomplish the ability to perform subsequent processing. Data security should go without saying, but it is always amazing to me how frequently we find that data warehouses are not backed up. Just because the word warehouse is used does not mean it is an exact replica of the source data. It is not the backup system for the source data. Much time and effort is put into what is called extract, transform, and load ETL processes, so the data is usable in the data warehouse. An attack on the data warehouse means that all of those efforts are for naught. Replacing the data in the warehouse means going back to the source systems, which hopefully are also backed up, and replicating all of the ETL processes. In preparation for ultimately loading data into the data warehouse, continuous validation of correct entry, auditing on a routine basis, and feedback to those entering data into the source systems is essential. Let's look a little bit more at what we mean by ETL. Continuing the discussion of data integration for convergence, we must look at the source data to be placed into the data warehouse, that they are accurate, and specifications for the analytics to be performed on the data are placed into the warehouse have been fully developed. Usually this is done in the form of data architecture, which is typically a big picture view of the data warehouse, and data modeling, which are focused views, often multiple focus views. Data extraction from the source system then can occur. The established rules for cleansing, scrubbing the data are applied to ensure the data are in the specified format for the data warehouse. The data are then loaded into the actual warehouse using data transfer protocols at scheduled times and with monitoring routines to ensure there are no issues in the transformation process. It is noted that data transformation is ongoing, generally according to the data loading schedule. It might be daily, weekly, or monthly. But because data in the source systems continue to reside in those systems as they are used in real time, some data might be changed due to error correction. And a fairly significant amount of data in healthcare source systems is certainly refreshed as patients get their temperature taken frequently or have repeat lab tests to ascertain improvements in their conditions. We don't replace the new temperature for the old temperature, but we have many temperatures being taken, for example. It is extremely important that the data architecture and data model or models for the data warehouse address what data will go into the warehouse and how new data for the same data element will be treated, date and time tagged, for example. There is also the possibility that someone can find an error in the warehouse, correct it, and not provide feedback to the source system. Hence, a reconciliation process with the source system is an ongoing process as data are continually extracted, transformed, and loaded into the warehouse. Upgrades to both the source systems and the warehouse are also factors that require attention when they occur. Finally, data loading is the process of scheduling and performing the actual transfer of the transformed data into the warehouse. During this process, there are usually yet another set of monitoring tools that alert when there are error conditions. Two other factors are important enough to call out in healthcare data integration. First is matching data correctly to patient and provider. We're going to look at the potential for a universal patient identifier, or at least an identification process, in a subsequent lecture. But at a minimum, each entity should have an accurate master patient index and resource for obtaining other linkage keys, such as to providers. These might be the National Provider Identifier or provider entities, such as the tax identification number. Part of the data coming from source systems will be coded, which means that every year there may be new codes and periodically an entire new code system, such as ICD-9 to ICD-10, which must be addressed in terms of how the data in the warehouse, which should be able to be compared over time, may need to be adjusted or mapped. So, what is the role of IT in data convergence? Well, data warehousing, as I said and suggested, is not for the faint of heart, and this is one reason it's often outsourced. But even if it is outsourced, in-house IT still plays a significant role. New knowledge and skills may help expand IT staff capabilities so they can really help optimize use of that data warehouse. Appreciating the difference between data versus intelligence may seem obvious, but many IT staff tend to focus on processing data and lack the skills to help users use the resultant information. Very many clinicians feel overburdened by data entry and often see no value or return in investment. Users detest what they call stupid and annoying alerts. However, users do want the right help. More sophisticated data visualization techniques can help supply intelligence. Should some clinicians want to interact more fully with the data, that should also be an option but not a requirement. But because EHR systems are designed for transactional processing with a focus on one patient at a time, they often lack these more sophisticated tools, and especially lack data integration and analytics capabilities. EHRs need to do much better than simply being a data entry tool. They need to support use of analytics in a way that brings intelligence to each of those unique patient encounters. They don't need to be a warehouse in themselves, but they need to be able to utilize warehouse data. An enormous volume of data is available in healthcare from many incompatible systems and siloed, even manual and incongruent data sources such as national registries, document scanning, clinical imaging, genomics, telemetry, billing, medical devices, and many other systems. IT staff must help users trust this data by processes enabling validity checking and error correction. There are also many regulatory constraints on data, and while privacy and security are extremely important, IT staff, along with all other staff, must understand that HIPAA is not a constraint when exchanging data across covered entities when used for treatment, payment, and operations. Providers may believe health plans use patient data for nefarious purposes, but they are still covered entities and patients do rely on them for payment of their claims. Disparate metrics and reporting requirements are often a result of other types of regulatory constraints or simply further siloing of data uses across the entire industry. Normalizing such data to the extent possible is a key function of data warehousing. Big data is defined by its volume, volatility, veracity, and value. Volume exacerbates the volatility of the data, especially when their source is disparate IT platforms. IT staff must learn to work either with data warehouses directly or with the contractors who are supplying the data warehouse services. Relying solely on contractors will not assure that the local source systems, both from the technology perspective and the user workflow perspective, can generate the data needed for a strong data warehouse. Multidisciplinary teams may result in episodic and fragmented accountability. In other words, who's in charge? Frequent delays in data movement can occur as a result. Over time, there has been significant shifting from centralized to decentralized and back to centralized and then again decentralized IT systems. There may be no one right way, but at a time when we're recognizing the importance of data convergence and learning data integration, everyone must work together. In the previous discussion, I alluded to the importance of workflow and process improvement. One factor that I believe is often overlooked as data convergence is contemplated and then performed is its impact on how healthcare processes are performed. A few examples are provided here with respect to financial, administrative, and clinical data convergence. Automated scheduling is not nearly as common in provider offices as in hospitals, but provider offices should become the first point of entry into the health system under value-based care. And cycling patients back to their primary care provider and specialist for care coordination is also a hallmark of value-based care. Provider office patient registration and scheduling systems should support direct data feeds to all other providers in their clinically integrated network. Automated point-of-care eligibility verification is another example. This extends the data system linkage challenge to health plans, and certainly in bundled payment programs, automated charging across the entire spectrum of the bundle makes it easier to both allocate payment across providers according to the negotiated agreements for the bundles and assure providers have data to evaluate where there may be weak links that need shoring up, such as one provider who delays treatment or has cost overruns. Decision support to automatically notify clinicians that key data are needed to avoid a claim denial is an unwanted necessity on the part of physicians. Not only do clinicians and especially physicians believe that all data entered into EHRs is done solely for billing purposes, but to have their clinical thought processes interrupted, if you will, with a billing issue has literally made physicians at least stop using EHRs altogether. IT staff should work with health information and informatics professionals and clinicians to determine what workflow would best accomplish getting the needed data while not interfering with clinical thought flow. Thought flow is a term coined by doctors Ball and Bierstock. Ball was a health informaticist and Bierstock a physician. As noted, the examples here are obviously related to payment, but value-based care needs workflow improvements to consider all areas of potential error, waste, time delays, and other factors putting both quality of care and cost at risk. New tasks and new ways care is delivered will even more require new workflow considerations. These include when and how patient risk stratification should occur and be used, engaging patients in their health care and shared decision making, coordinating care across the continuum and with community services, using telehealth, working with patients' mobile health devices and apps, and even coordinating care with retail clinics, retail pharmacies, and other new business models. How data are brought together in the convergence process can actually help identify opportunities for workflow and process improvement.